I thought I'd try to address some of the questions the library organizers of this event sent out when they asked me to come and speak. The first question on the list they sent was, what constitutes universal health care? And for the purposes of my presentation today, by universal health care, I mean a system that allows access to health care based on need and not ability to pay. So I'm referring to a system of public funding that is accessible to all members of our community. So, for example, most doctors, even though they run their own private practices, are part of universal health care because patients are able to access them as long as they have a care card. Physiotherapists, unless they work in the hospital, are no longer part of universal health care since public funding for this service was cut in 2001. So does Canada have a universal health care system? The answer to that is about 2/3 yes and 1/3 no. At present, about 70% of our health care is publicly funded, and 30% still depends on the ability to pay. Dental care, drugs, community-based physiotherapy are all services that are privately funded. In fact, Canada ranks 17 out of 30 OECD countries in relation to the proportion of our health care that is universal or publicly funded. And many European countries have far more universal systems than our own. The second question on the Vancouver Public Library list was, is universal health care important? Two recent commissions, the Romano Report and the Kirby Commission, concluded that ordinary Canadians place high value on a system of universal access. Many Canadians are aware of the high cost of health care in the US, where the #1 cause for personal bankruptcy is inability to pay for costs of health care when faced with illness. And most of us aren't comfortable with a system that would allow that to happen here. The business community has also noted the economic advantage of Medicare, where in the US, benefits have been reported to be a key factor in 55% of all strikes. The Toronto Dominion CEO, in a speech to the Vancouver Board of Trade in 1999, described Medicare, and I quote, as an economic asset of our country that we dare not lose. So in answer to the Vancouver Public Library's second question, it would appear that most people feel that universal health care is very important. But beyond the issue of what we feel or believe, what are the facts? And this leads us to a third Vancouver Public Library question, which is a public system funded by the government the best way to meet healthcare needs? Would our system be better served with the introduction of parallel private insurance that allowed those who could pay to get their surgeries done sooner? Let's look at the evidence. And by evidence, I mean studies conducted by academics with no vested material interests in the topic and whose work has undergone rigorous peer review. We now have good evidence that publicly funded healthcare is cheaper and far more efficient compared to private insurance. Multiple studies across many jurisdictions and countries have demonstrated this to be the case. Private insurance companies have to develop insurance packages, market these policies against the competition, assess claims, and satisfy their yearly investors. All this jacks up the cost of healthcare. There's also good evidence that wait lists get longer when doctors and nurses work in public and privately funded systems at the same time, as these scarce resources are now spread between both sectors. There are many examples from Great Britain, Australia, and Canada that demonstrate this. Australia, with a healthcare system very similar to ours in the past, introduced a system where a large proportion of the population is now covered by private insurance, and the results have not been good. Wait lists remain long for publicly funded patients, and Australians are facing major problems of equitable access that do not exist in Canada. The government in Australia has also had to bail out the private insurance part of the system and introduce tax incentives to convince people to buy private insurance. We have good evidence that user fees don't save money and discourage those who need care most from seeking it, thereby potentially increasing the costs of downstream complications. Again, our two commissions, Romano and Kirby, both very prestigious and well-recognized, reviewed the available evidence on these questions and all came to the same conclusions that I just outlined. My own professional association, the Canadian Medical Association, endorsed a report on the topic this year, which concluded that private insurance for medically necessary services does not improve access, does not lower cost or improve quality of care, can increase wait times for those who are not privately insured, and could worsen the shortage of healthcare professionals in the public system. So to answer the question, is a public system funded by the government the best way to meet healthcare needs? The answer is yes, it is. So how about on the delivery side? This leads us to the next Vancouver Public Library question. Can our healthcare be better provided through a single government-controlled model, a totally privatized model, or a mix? In other words, services would still be universal, accessible to all who need them through a government-run insurance system. But should we increase the role of the private for-profit sector in the delivery of care? Here too, we already have some mix. Physician services, some pharmacy services are all publicly funded and yet privately delivered. Should we expand this? Would this make us more efficient? This is currently on the table, particularly in relation to establishing for-profit surgical clinics where groups of entrepreneurs would be encouraged to bid for government contracts to perform outsourced services outside of public hospitals. Again, the evidence tells us that corporate for-profit healthcare, even if it is publicly funded, will not improve outcomes and tends to undermine the public system. Such clinics must make their profit by what is called cherry picking. That is, in order to be able to generate a profit, they have to make sure that the cost of a procedure is less than what the government pays them to do the procedure. Such clinics tend to only accept the easier patients, leaving the more complicated ones to the public system, and when surgical complications do arise, these patients get transferred back to the public system very promptly. Staff working at these clinics, nurses, often keep their part-time status in the hospitals so that they can retain their pension and other benefits there while drawing a higher wage in the private clinic. Offloading complex patients and the cost of staff benefits onto the public system are two ways that for-profit clinics can generate a profit at the expense of the public system. Some walk-in clinics do a very similar thing in primary care. Many such clinics, the walk-in clinics, make their money from the easy one-time visits such as colds and coughs, where full-service family doctors are paid the same amount per visit to provide continuity of care and address multiple problems for complex patients with chronic disease. I can tell you that walk-in clinics have been a very big factor in increased workload and burnout for family doctors. The widespread introduction of private surgical clinics may well have the same effect of undermining public hospitals by placing an unequal burden on these already stressed institutions. Finally, most peer-reviewed studies have been done comparing health outcomes in publicly funded nonprofit versus for-profit delivery models, show lower mortality rates for the nonprofit hospitals and for renal dialysis clinics, and they also show better outcomes for primary care preventive measures like Pap tests and immunization. So there's good evidence in all the comparative research that's been done on this question on the delivery side. Now, there's some that argue that private options give us more choice. However, receiving health care is not like choosing a hamburger or buying a car. Patients often seek medical advice when they're feeling sick and vulnerable and are in no position to test drive or taste their options. There are large asymmetries of information in healthcare. On many occasions, a patient has said to me, "You decide, doctor, whatever you think is best." If physicians also happen to have a strong vested material interest in the type of choices patients make, there is potential for abuse. So while the expansion of private delivery of services is not a direct challenge to the universality of our system, it still does not appear to be a good idea, given the evidence and ethical arguments against this. The next question on the Vancouver Public Library list that I'd like to address is, what is the experience in other countries? And how does Canada's healthcare system compare to the others? Let's start with the US. In this country, 44% of all healthcare is publicly funded, and 15% of the total GDP, that's the total wealth of the country, is spent on healthcare. Canada devotes more of its public funding to healthcare, 70%, and only spends 10% of our total wealth on healthcare, our GDP. A recent article illustrating this was published last year in the Archives of Internal Medicine. This article compared outcomes and cost of coronary artery bypass graft surgery in Canada and the US. There was no difference in in-hospital mortality between the two countries. Hospital length of stay was actually slightly longer here than in the US, but the cost in the US was 82.5% higher. Authors attribute the difference to higher direct and overhead costs, 82.5%. Overall, compared to the US, Canada also has lower mortality rates and better outcomes for a wide variety of specific health problems, from renal failure to cystic fibrosis. So our system is more fair, we spend less, and our health outcomes are better than in the US. How about the rest of the world? How do we compare to the other OECD countries? France and Germany seem to be doing better than we are. They have shorter wait lists and better access. This is not because they have more private health care in those countries, but the opposite. In both of those countries, a greater proportion of health care is publicly funded. And because publicly funded health care costs less, the European healthcare dollar in these countries therefore stretches farther, allowing these systems to be more efficient. France and Germany also spend more of their GDP on healthcare than we do, and they pay their physicians less than we do. These are likely reasons why France and Germany are doing better than us. So given what we know about how we should be doing things, why do we continue to grapple with how to do things in healthcare? Unfortunately, the crowding in emergency departments is real, and most of us know someone who's waited too long to get a surgery or necessary treatment. If the public system did not have these problems, the privatization argument would have no fertile ground on which to grow. So why do we continue to face these waits and the overcrowding in emergency departments? Well, firstly, federal funding to healthcare was cut back in the 90s. We capped the number of doctors being trained, and we closed down many hospitals. Then, in 2001, our provincial government undertook further closures of hospitals and long-term care facilities. In long-term care, the residents being admitted to these facilities are sicker and more complicated, with very little changes to the staffing mix in the facilities. Last year in BC, there were over 53,000 ambulance transfers to the emergency department of residents from long-term care facilities. So these issues, the cuts to healthcare in the 90s, the rapid expansion of technology, and to a lesser extent, the effect of our population aging, have all resulted in the pressures we now see and allow the privatization argument to gain ground in spite of the evidence. But it is also clear that when we put our minds to it, the public system is actually able to solve problems quite quickly. In Richmond this year, in British Columbia, a pilot project launched, no, it was actually not this year, it was in 2004, to improve wait lists for knee and hip surgery, was able to reduce wait times by 27%, and hospital lengths of stay were also reduced for these surgeries, thereby freeing up more hospital beds and reducing waits, all through good leadership, some additional funding, and applying the science of what we know about how to best practice those types of orthopedic surgeries. The North Shore has also improved their orthopedic wait list in a very similar way, as have many other jurisdictions across Canada. In primary care, I have the privilege of working at a community health center with a team of other family physicians, a pharmacist, a nurse practitioner, and a nutritionist. We provide 24-hour care, continuity of care, have an electronic medical record, and have been able to implement very effective systems for supporting those with chronic disease to better manage their conditions. The team functions well, and we're generally an enthusiastic group of primary care clinicians and not burned out. This is quite unusual. The public system is capable of fixing things with the political will, the necessary resources, and the right leadership. And in fact, it's exactly the pressures on our system that make it so important to reinforce and expand the public system. We can't afford to not reinforce a system which is proven to be cheaper, more efficient, and accountable. I would like to end by challenging all of us to encourage our leaders to carefully examine the evidence and to build sustainability in healthcare by expanding and improving the public system. Thank you.